My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to COAG Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. I'm George Fritzma, faculty at the University of Alabama at Birmingham School of Medicine, Division of Laboratory Medicine, and proprietor of The Fritzma Factor, your interactive hemostasis resource, where we exchange current information on coagulation mechanisms, clinical observations, and the role of the laboratory in diagnosis and management of disorders. We welcome you to our three-part series, Managing the Direct Oral Anticoagulants, commonly named the DOACs. Our guest is Dr. Karen Moser, Medical Director of the Hemostasis and Thrombosis Laboratory at ARUP Laboratories in Salt Lake City, Utah. She's also an Associate Professor of Pathology at the University of Utah School of Medicine. Dr. Moser received her medical degree from St. Louis University and served her residency at the University of Utah School of Medicine. She also served a fellowship in hematopathology at the University of Utah School of Medicine. She's certified by the American Board of Pathology in anatomic, clinical pathology, and hematology. Her research interests are in laboratory hemostasis and thrombosis testing and medical education. Thanks for returning to our COAG conversation. Part 1 is now available on our Biomedica Diagnostics website. That's the one that's entitled DOAC History and Clinical Use. Part 2, DOAC Measurement, has now also become available. And again, we encourage your comments. Our third discussion now addresses DOAC risks and reversals, but we'll start by talking about how the DOACs affect other hemostasis testing. Dr. Moser, can you comment on that, please?
Of course. This is a heartburn issue for those of us that work in the clinical hemostasis laboratory. We want to generate good and reliable results, and when there's anticoagulants that can interfere, it makes it challenging to know what we're looking at. So any of our clot-based assays can be affected by the presence of direct oral anticoagulants, and I'll share some highlights here. So some of our tests can have a false increase in value, and many of our thrombophilia assays fall into this category. So protein C activity, protein S activity, antithrombin activity, and activated protein C resistance can be overestimated in the presence of DOAC. And what that means for these tests is that we have a risk of calling a patient affected by deficiency of protein C, for example, normal. So it's a false negative result, which can be challenging. Few caveats here. Protein C activity assays that are clot-based are affected by the presence of DOACs. Chromogenic protein C activity assays aren't affected. And the antithrombin assay design determines which of the DOACs will interfere, whether it's a 2A-based assay where direct thrombin inhibitors can interfere, or a 10A-based assay where the direct 10A inhibitors can interfere. But wait, there's more. So we also can see interferences in factor assays. We can see decreased activity and or a non-specific inhibitor effect, meaning increasing value with increasing dilutions. in factor assays. And lupus anticoagulant testing is another key area that is affected by the presence of DOACs. And we often see DOACs present in samples or specimens, submitted for lupus anticoagulant testing because these are patients that develop clinical thrombi and need to be treated with anticoagulants. So it's a pretty common interference. Lupus anticoagulant assays, including both DRVBT and PTT-based assays, can have false positive results, particularly with rivaroxaban. And in rare cases, false negative results have been reported. Apixaban is the drug I'm thinking of that's been reported to have a false negative result. So there's definitely the possibility of unreliable lupus anticoagulant results when DOACs are on board. But wait, you say, we as clinical laboratorians have a lot of experience with getting rid of anticoagulants that we don't want to be there. We know how to use heparinase. We've used polybrine. We can get rid of heparin like nobody's business. So why can't we get rid of the DOACs too? Well, we might be able to. There are some agents that have been described fairly recently that neutralize the DOACs in plasma specimens in the clinical laboratory. There are some tablets that contain activated charcoal, as well as one filter system I'm aware of that have been described. Of these, the tablets are commercially available for purchase. So you drop it in, let it soak up the DOAC, centrifuge it out, and remove the activated charcoal-based stuff, and you have a plasma specimen that's free of DOAC that you can then use in any of your clot-based assays. So that's a really exciting development for those of us trying to provide high-quality hemostasis lab results. I will say that some groups have reported decreased factor activity, so some kind of non-specific absorption maybe of other factors after using DOAC neutralization tablets. Not everyone who's published in this area has reported that, but it definitely needs some further study to confirm or refute those observations.
That really is exciting news. It's good to know that we can neutralize those DOACs and get some accurate clot-based results. One other question that comes up in my mind relative to testing and the effective results is, what do we do when we're transitioning from, let's say, an anti-10A DOAC to unfractionated heparin? How do we manage that in the laboratory?
Oh, that's tricky. And we've had quite a few questions about this exact scenario in my laboratory recently. So it often comes up when a patient who's on a direct 10A inhibitor at baseline needs to be hospitalized. Somebody wants to transition them to unfractionated heparin because it's easy to reverse. Maybe they need a procedure. So yeah, then what to do, right? So we're starting this patient who has existing direct 10A inhibitor effect in their plasma. We're adding unfractionated heparin to the mix. And now their physician says, I want to monitor unfractionated heparin, because that's what I do. It gets pretty tricky because heparins also have anti-10A activity. So if you use an anti-10A activity assay, there really isn't a way to separate out the relative contribution of the direct 10A inhibitor versus the unfractionated heparin in that anti-10A activity assay. So it doesn't work particularly well in that context. The PTT might be of some help when patients are starting on unfractionated heparin and transitioning from a direct 10A inhibitor. It really depends on the PTT reagent sensitivity to the particular direct 10A inhibitor the patient is taking. So it requires some knowledge of your particular local PTT assay and the drug in question. Of course, there's still some possibility of the direct 10A inhibitor interfering in the PTT, so it's not a perfect solution. The good news is once the DOAC is cleared from the patient's system, they tend to have a fairly short half-life, relatively, then heparin monitoring can proceed as usual. It's just that small window when both drugs are present that makes it difficult to get a reliable laboratory measurement.
Just seems like whenever we think we know everything about coagulation, something else comes up like this. And the next thing is an issue that happens, I'm sure, UAB, where I am, is no different than any other facility around the country in that we get a lot of people who have overdosed on their DOAC in the emergency room, and now they're bleeding. Is there anything we can do about that?
Yeah. So is there a way to effectively and safely reverse the effects of these DOACs?
Mhm.
When they first became available, sadly, the answer was no. But in 2022, the answer is yes. Reversal agents are typically reserved for patients who have serious or life-threatening bleeding, or maybe in cases where there's an emergent invasive procedure needed and there's not time to wait for the DOAC to clear out of the patient's system. There are some drug-specific DOAC reversal agents. One is idarosizumab, which reverses dabigatran effect, and andexanet alpha is approved to reverse rivaroxaban and apixaban. These agents are fairly expensive, and when they first became approved, they weren't widely available, although availability is increasing with time. It's a difficult area for clinical decision-making because we're always balancing the relative risk between stopping bleeding that might be life-threatening and potentially causing thrombosis. And we don't have a lot of data to guide these decisions. This is something, again, that we're continuing to learn about. I will point interested listeners to a 2019 guideline from the Anticoagulation Forum that offers some guidance for the use of idarosizumab and andexanet alpha and can be a good resource in navigating these challenging situations. The other thing that's been described in the literature is the use of prothrombin complex concentrates, either activated or unactivated, to reverse DOAC effect. And some groups have reported success for that. I would caution that that's an off-label use of those products, but it's another thing to consider in these urgent, life-threatening situations.
I know that bleeding is still a risk with the DOACs. And is there any other risk? What about the possibility of rethrombosis in the patients who are taking DOACs? Is it more effective than, say, heparin or warfarin? And how serious is the bleeding problem?
Right. So those are the big things we worry about with any anticoagulant: bleeding, thrombosis, and it's really important to counsel patients about those risks before they start taking these drugs and give them some guidance for what to look for. So we do know that the risk of major bleeding with the DOACs is somewhere in the range of 1 to 3% across the variety of clinical trials that have been performed to date. And there's also a risk of breakthrough thrombosis, again, about in the range of 1 to 2% across a variety of clinical trials on the whole. Let me share an image I have here. When directly compared to warfarin in clinical trials for stroke prevention in atrial fibrillation, apixaban, rivaroxaban, dabigatran showed lower overall bleeding rates than warfarin. Although as we've learned more about how these drugs perform, it seems that GI bleeding risk may be slightly higher with DOACs, or at a minimum similar to warfarin. Doesn't seem to be better. I'm not really aware of large clinical trials comparing the bleeding risk of the different DOACs to each other. They've all been compared to warfarin, but I'm not aware of head-to-head comparisons. And it's been interesting over the past several years to watch real-world use case bleeding risks be reported in the literature. So, of course, clinical trials are really optimized environments. We have carefully selected patients in a small number of centers. And so that's kind of the best case scenario, but clinical practice varies a lot more. And DOACs are being used across a wide spectrum of patients in many, many different settings. So I'm sharing here some data that were captured from the US FDA Adverse Event Reporting System, showing relative reports for a variety of different thrombotic and bleeding complications, and relative rates for the different drugs, dabigatran, rivaroxaban, and apixaban. One thing that's interesting to me is that in this diagram anyway, apixaban looks like there are fewer reports, But I think we have to be careful because there's only 1 year of data for apixaban included in this snapshot in time. So as more time goes by where apixaban is in clinical use, you might expect those adverse events to look relatively similar to the others. Most of the adverse events reported with DOAC do tend to involve bleeding, but you'll notice in this particular snapshot from the FAERS reporting system, rivaroxaban seemed to have a relative increase in PEs and DVTs reported, and it's not entirely clear to me why that tends to be relatively increased for that drug. But that is what the snapshot saw. So I think this is an area, again, where we're continuing to learn. We're seeing how these drugs perform in clinical practice and figuring out how they really look in the real world.
Dr. Moser, this problem has come up a lot at UAB, and I've heard from one or two of the pathologists there. A patient comes in, they're bleeding. You ask them, what are they taking? They say, a blood thinner. That's as far as it goes. What can happen is that perhaps the emergency room physician will select the andexanet alpha to treat the individual without knowing if they actually had an anti-10A like rivaroxaban or apixaban. And then they've not only cost a lot of money, because those things are still pretty expensive, they also run the risk of creating a prothrombotic situation. Is there anything we can do about that?
So you're highlighting the need to really know what we're dealing with. It's if we're going to use a targeted reversal agent, if we've determined that clinically that's the best step, it's really helpful to know what we're trying to reverse so we can choose the appropriate agent. And so to do that, you'd have to have a relatively rapidly available result to say, hey, it's rivaroxaban or it's dabigatran. This is what we're up against. And we've already highlighted some of the challenges with getting rapid results given the assay landscape that we have right now. So something that you could do at the bedside in the emergency department would be really attractive in that scenario. I'll just share, there is one rapid test that I'm aware of that is not yet FDA approved and only has some very preliminary data available. That's a dipstick test performed on urine that can say, it's again a qualitative assessment of whether there's dabigatran or direct 10A inhibitors present in the urine. So something like this, if it were to be confirmed to be a robust measurement and meaningful measurement, could be an attractive option in those scenarios. But again, what we know about this dipstick assay is pretty preliminary at first, but a concept like this would be promising in those emergent situations.
That's exciting to know. And as a med tech who's done an awful lot of urinalysis, that's a nice approach, I think, very easy. Is there, I know there's more research that's going on to develop more DOACs. Are there any possibility of developing DOACs that have a lesser risk of being associated with hemorrhage?
There might be. This is, again, something that we're continuing to learn more about. So there's a few additional promising agents that are on the horizon, but we're in the very early stages of starting to understand their clinical performance and their effects on bleeding complications. There are drugs that are targeting either factor 11 or factor 12 that are under investigation. These factors are now thought to play a greater role in thrombosis than in hemostasis, and so they may have the potential to prevent thrombotic complications with a relatively minor risk of bleeding. That's exciting and definitely something different than the agents in our toolbox right now. This hypothesis that they might have a lesser risk of bleeding stemmed from the observation that patients with contact factor deficiencies like factor 12 don't have an increased risk of bleeding, and that factor 11 deficiency is rarely associated with spontaneous bleeding or a more minimal degree of bleeding than some of the other factor deficiencies that we see. So I know that there are some anti-factor 11 agents that have ongoing or recently completed phase 2 clinical trials. There are oral agents that are small molecule inhibitors, and there are some parenteral agents that are antibodies or antisense oligonucleotides. And I know from the phase 2 trials of one of the small molecule inhibitors and monoclonal antibodies directed against factor 11, these agents seem to be effective in preventing venous thromboembolism in patients who receive these drugs after knee arthroplasty. They were compared with enoxaparin, one of the low molecular weight heparins, and it's not clear that the anti-factor 11 drugs are superior to enoxaparin, but they at least appeared comparable. And the anti-factor 11 drugs did not show an increased risk of bleeding as compared with enoxaparin. But again, these are just from initial phase 2 trials. We definitely need larger trials across a variety of indications to really evaluate the bleeding risk and efficacy of these agents. But it's an exciting new possibility.
That is exciting news. This concludes our series, Measuring the Direct Oral Anticoagulants. All 3 parts of this discussion are now available on the Biomedica site. Dr. Moser, thank you once again for sharing your expertise, and also thanks to our audience for your participation. We encourage your questions and comments. Again, thank you very much.